Good evening, everyone. How are you all? Thank you so much for joining our tonight's session. So, what I actually felt today is that many of you had a lot of questions about the course in our last session. We were running out of time, so we had to stop. Even we were running out of time, still we wanted to discuss everything with you. So I thought, like, let's start by showing some of the course details with you while everyone is joining. So you must have just listening to the video and also watching the video. So that's actually how the course is going to work. As you all know that this is our part of the 2 weeks free sessions. We have already started the session. You had few sessions with us already. One of them was psychiatry mental status examination. We took a theory session as part of our trial class. And also just few days ago, we also did a role play on that particular theory session. So that's how normally we work. We do a theory session followed by a role play on that particular topic. Just like that, we are going to do cardiology tonight. And cardiology is one of the most important medicine related topic that can appear in your exam. Almost every month we see that questions are coming from cardiology. And it's actually a really important topic even when you will be working in Australia. So we're going through those important cases tonight, and you are going to see how actually our course classes works, how we normally do our theory sessions. So many of you must have heard about our cluster-wise approach. Our cluster-wise approach makes your preparation really, really easy. And not only just that, because we have a cluster which gives you a format of a particular history for 6 to 7 cases. So with just one history and physical examination format, you actually can finish 6 or 7 cases using the same questionnaires, using the same physical exam. In that way, you don't need to prepare yourself for, let's say, 300 cases. If you do some course where every cases they're discussing as a separate case, that becomes a huge load of preparation for you. And I would never recommend anyone to do that, because you can't remember 300 cases in the exam, but you can remember particular format. And if you know how to approach a particular thing, then it's not very hard in the exam to remember those format and just deliver it accordingly. Okay, so tonight we are going to show you one of the important cluster that will help you in your exam in a lot of ways. Understanding how to take a history from a patient in the exam, and also how the theory sessions, especially medicine theory session works, you're going to understand today. Many of you who are here, I know that you are already our course student. So this is a part of your course class already. And I would obviously recommend all of you who has already got access to our portal, please start going through the cases that we are doing. Make sure you do role play from the start with your partner. And when we are asking you to do role play with us in the class, just make sure that you come forward and do the role play with us. That will make sure that you have enough confidence to appear the exam. And it will boost your confidence a lot if you can do it with us. Okay, all good. So I guess all of you can hear me, obviously, right? You are ready for the class now? And if there is any questions, tonight I kept a little bit more time for you to answer any questions that you might have. So anything that you want to know about the course, please keep it for the end of the session. I will answer you as long as it takes. Okay? So because it's Saturday, I don't have to go to work tomorrow. So I can answer any of your questions. Okay? All good. Let's start. So cardiology, first cluster that we are going to do is called syncope cluster. Now, you might be, sometimes you might try to unmute yourself and then ask questions. We normally keep you muted for the duration of the class just to make sure that there is no background noise. Because sometimes what happens, people, they are not aware that their mic is on, and we can hear them saying everything at their home. Maybe their babies are crying. So a lot of things happens. So just to make sure that we don't get disturbed in the class, we keep it muted, but you can always write anything on the chat box. For those of you who are in Facebook live session, you can also write it in the comment section. I will go through that. Okay. So let's start with our syncope cluster today. So what is syncope? Syncope means loss of consciousness, and it's a sudden loss of consciousness. When a patient comes to you with a history of syncope, what are the main differential diagnoses that we should look for? So differential diagnosis is the most important thing that you should make sure that you remember in the exam. In the outside 2-minute time, the first thing that should come into your head is that what are the differential diagnoses of this particular case? Because if you can remember that, and you can remember with any mnemonics or any other way, that's going to help your history a lot. And if your history is normal, if you can finish your history in time, it's likely chance that you're going to finish it within time, and likely chance you're going to pass the station. So history is the most important part of your case. If you can do it right, everything is right. And to get it right, you need to know this differential diagnosis. So memorize the differential diagnosis in any way that you can remember. So what are the differential diagnoses of a patient who presents to you with sudden onset of syncopal attack? So it could be CVS related, CNS related, or miscellaneous. So the CVS related could be arrhythmia. So any arrhythmia can cause syncopal attack. Aortic stenosis is one of the important valvular disease which causes syncope. HOCM, so hypertrophic obstructive cardiomyopathy can cause it. We should always rule out the possibility of ischemic heart disease or myocardial infarction. Part of arrhythmia would be also prolonged QT syndrome. I kept it as a separate one because it's one of the exam case. So just make sure you remember it. So these are the CVS causes. So arrhythmia, ischemic heart disease, valvular heart disease, and HOCM. CNS. So what are the CNS causes? It could be TIA or stroke, could be head injury, infection like meningitis, encephalitis, or could be just a epileptic attack. Others also very important. So it could be a vasovagal syncope, could be postural hypertension causing it, could be hypoglycemia, anemia, sometimes some medication, especially the medication who can reduce your volume, like diuretics or any other antihypertensive medication, can result in syncope. Sometimes it could be just a part of a stress or psychogenic presentation as well. Could be brain tumor. Yes, that's right. So brain tumor usually doesn't come with sudden syncopal attack, but yes, that can be one of your differential diagnoses as well. So these are the main differential diagnoses that we are going to rule out. What are the important case for exam? So in the exam, aortic stenosis is important. Myocardial infarction is always important, but it doesn't come as syncope in the exam, but rather comes as chest pain case. Prolonged QT is important. Usually in the exam, CNS causes doesn't come with syncopal attack, but still we should rule that out. Vasovagal syncope comes in exam. Postural hypertension is super important. So these are the main causes. Okay. Let's start with the history. So how to take a history when a patient presents to you for the first time with a syncopal attack. Now I'm going to discuss the both format of examination, how it's going to work in your exam. So most of you know that in face-to-face exam, when you go to the room, there will be an examiner and the role player. So you can ask questions from the examiner, and examiner will give you those questions answered. Whereas in online exam, there will be an examiner on the video, but that means on your Zoom session when you are taking the exam, but the You can't see the examiner, so video will be off, and you can't talk to the examiner. So examiner is not going to answer anything that you're going to ask. So the format is a little bit different from face-to-face and online. So let's see how the face-to-face usually should work. So we say that, let's say it's a 70-year-old patient coming to you with sudden onset of loss of consciousness that happened yesterday. So your task is to take history from the patient, physical examination from examiner, and give your diagnosis and differential diagnosis. So that might be one of the tasks. So first of all, let's say that how we are going to start a case from a patient. So let's say patient name is John. So hi John, this is Dr. Arshan. I'm one of the doctors in this clinic. It's very nice to meet you. I understand from the notes that you had a sudden loss of consciousness yesterday. I'm very sorry to hear that. How are you feeling now? Yes, doctor, I'm feeling okay now. Well, that's really good. John, I want you to know that now that you are here, I'm going to take care of you and find out the cause of your symptom. But before I ask you any more question, I just need to ensure that you are stable enough. So please excuse me for a moment. I'm going to talk to my examiner and come back to you. Then, because you will be sitting on a chair, so turn around towards the examiner and ask, dear examiner, I would like to know if my patient vitally stable for further history. Two things can happen. Examiner can say, what do you want to know? Or examiner can say, stick to your task. If examiner says, stick to your task, then you just thank the examiner and come back to the patient and start asking questions. If examiner say, what do you want to know? Then you should say one by one, doctor, I would like to know his blood pressure, sitting and standing, pulse, rate and rhythm, please. So we can only ask 2 questions at a time from the examiner, not more than 2. So what are the vitals that we should ask from examiner, right? So the vitals that we are supposed to ask is blood pressure, pulse, respiratory rate, temperature, and oxygen saturation. So these are the 5 things that we normally ask from examiner. We can't ask ECG in the initial part, okay? So first of all, we're going to ask examiner, I would like to know his blood pressure standing and sitting position and his pulse with rate and rhythm. Examiner says, gives you the numbers, and then you ask, I would also like to know his temperature, respiratory rate, and oxygen saturation, please. So you can say 3 and 2 in that way. That's all good. Once you know that patient is vitally stable, then you thank the examiner and come back to the patient and say, thank you so much, John, for waiting. Now, would you please tell me a little bit more about what exactly happened yesterday? So that's your presenting complaint, which is syncope. And we always start with an open-ended question. So first ask the patient what exactly happened. Now, syncope cluster, we divide it into pre-syncopal question, syncopal question, and post-syncopal question, which means what happened before syncope, during syncope, and after syncope. Okay, now just give a pause over here. Let's think what's going to happen in online exam. So in online exam, because examiner doesn't answer your question, so you can't ask anything. What I normally say to the candidate to do is that, say that, dear, hi John, this is Dr. Arshan. I'm one of the doctors in this clinic. It's very nice to meet you. I understand from the notes that you had a loss of consciousness yesterday. I'm very sorry to hear that. How are you feeling now? I'm feeling good, doctor. Well, that's very good to hear. John, please be reassured that now that you are here, I'm going to take care of you and I'm going to find out why did you have loss of consciousness yesterday? And I'm going to manage you accordingly. I will also make sure that your vitals are stable so that you are fine to proceed with the history. Is that okay with you? Yes, doctor. Well, John, please tell me a little bit more about what exactly happened yesterday. So what did I do is that I told the patient that I will make sure double, but because I can't ask it to the examiner, I haven't done that. I just say to the patient, an examiner will understand that we can't ask it to the examiner, but we are saying initially that we are going to check your vitals first. Is this understandable for everyone? And they are not going to bother you about it because they know that this is what we can do only. So Dr. Mariam, what I said is that you do the same thing, but you just say that I will, John, before I ask you any more questions, I will make sure your vital is stable, and then I would like to ask more questions. Is that okay with you? John says, yes, doctor. So you are not going to ask it to the examiner, just go to the next thing. So John, would you please tell me a little bit more about what exactly happened? So you just jumped one step because that step you can't do in online exam. Clear? If patient comes just after episodes of syncope, that's fine. We are going to make sure patient is vitally stable first, right? So anything happens, that's the reason that even if patient comes just after an episodes of syncope, obviously patient is not now having consciousness. That's why he can talk to you. So it's the same approach. That's one of the reasons why we want to make sure that this time patient is stable enough. Okay, so same thing, nothing is different. Starting with the history, so your pre-syncopal questions, first of all, can you tell me a little bit more about what exactly happened? So patient will always give you enough information that they're supposed to give it to you. That's why we say that if you don't ask an open-ended question, most likely some of the important information can be missed. So always ask an open-ended question first. After that, whatever you get from the patient, please do not repeat it again during your next history. So listen to the patient carefully. If you, let's say patient says, doctor, I had a fall yesterday. And your next question is, when did you have your last fall? That means you did not listen to the patient correctly. And that's the reason why you just ask the question that has been already given by your patient. A lot of candidates, they do that in the exam so frequently, examiner and the role player get pissed off. The reason is that if you ask an open-ended question, you need to listen to the patient, what information they are giving you. And you are supposed to only ask the rest of the question. In the note, we write everything, but that doesn't mean that you will ask everything in the exam. You will only ask the information that was not given by your role player. Okay? So you need to find out that what exactly were you doing at that time, and is it for the first time that happened? Now, many times patient can say, no, it is not the first time. Then what you need to ask that you need to go a little bit more detail about the past history. So you have to say, so how many times before you had it? Can you describe those episodes as well? Because you need to know that if there is any connection between any particular event or situation that's causing this syncopal attack. So if patient say first time, that's fine, you go to the next question. But if patient say no, you need to go in a little bit more. So how many times before? What exactly were you doing at that time? What did you do at that time? Like, did it stop suddenly, or did you need to do anything to make you feel better? Or did you see any doctor? Did you come to any clinic? So few questions you need to dig in at that time. After that, did you fall suddenly, or did you feel any symptom like lightheadedness or dizziness before you fall? Many times there is some prodromal symptom before a syncopal attack, which is what we call as, usually in vasovagal syncope, patient knows that they are going to fall. That means they get this kind of feeling, they get blurring of vision, they might get a little bit of like sweaty, clammy, they also get lightheadedness, and then they have a fall. So those prodromal symptoms are a feature of vasovagal syncope, but if it is a cardiogenic syncope, then it will happen very quickly without any prodromal symptom, and patient will recover very quickly as well. And then there will be no confusion after gaining the consciousness. So that's cardiogenic syncope, which happened rapidly, and consciousness also regained very rapidly without any post-event confusion. Whereas in epilepsy, after an epileptic attack, patient can get even 30 minutes to 1 hour post-ictal confusion, right? So those are the important things that will lead us to find out our diagnosis. So did you fall suddenly? If yes, then it's a cardiogenic syncope, so something cardiac. Did you feel any lightheadedness or dizziness before you fall? If yes, then we are thinking about a possibility of vasovagal syncope. Ask about any other symptoms like any headache, blurry vision, any weakness in any part of your body to rule out any CNS causes, especially TIA or stroke. After the pre-syncopal question, next is syncopal question. So what happens during syncope? So was there any witness? Because patient will not know what happened after they lost their consciousness. So was there any witness when you had this episode? If they say yes, we are supposed to say this line that if you please give me the consent, I would like to ask what happened when you lost your consciousness from that person. So if they say that, yes, my mother was with me and she witnessed the event, then you can say, if you give me the consent, I would also like to ask a little bit history about it from your mother. Just say that line. You are not going to do that in the exam because there will be only one role player, but we should say this line. After that, did you lose consciousness? If yes, how long was that? Did you have any jerky movements of your body? Did you wet yourself or pass a stool? Did you bite your tongue? And by any chance, you injured your head? Because patients have a fall when they lost consciousness, it's always important to make sure that they did not hit their head. Okay, so what we are mainly ruling out in syncopal question is epilepsy. So jerky movement, did you wet yourself or pass a stool, bite your tongue? And then we move on to the post-syncopal question. So what happened after you regained consciousness? So after you gained your consciousness, were you able to stand by yourself immediately or someone helped you? Why we are asking this question? If patient says, after I gained my consciousness, I was totally fine, I could stand by myself. What does it mean? Likely that is a cardiogenic syncope. If patients say, no, I was a little bit dizzy, lightheaded, I was confused, then you think something else. Could be neurogenic, could be any of those vasovagal as well. Did you feel confused and drowsy? If they say yes, then how long were you confused? Any weakness or any problem with your vision or speech? Again, to rule out any CNS cause. So that's your pre-syncope, syncope, and post-syncopal questionnaires. We have to ask each of these questions one by one. Once we have done our history of presenting complaint, which we are going to say always as HOPC, the next is differential diagnosis. So the format is always crystal clear. You first make sure patient is vitally stable if it is an acute case. Second, you ask in detail about the HOPC, and then you move on to the differential diagnosis. So what are the differential diagnoses in this case? Serious. So for serious, just quickly ask any chest pain, any difficulty in breathing, any racing of your heart. So that will rule out every serious symptom. So chest pain, shortness of breath will cover myocardial infarction, ischemic heart disease. Even shortness of breath is a feature of aortic stenosis. Racing of the heart will cover any arrhythmia. Then move on to CNS. If you forgot to ask about head injury, so ask it here and rule out any possibility of infection of brain. So meningitis, encephalitis. So any fever, rash, or neck stiffness. Then you move on to the miscellaneous causes. So first of all, hypoglycemia. By any chance, did you skip your meal before this incident happened. So if it happened today, then ask, by any chance you skipped your meal? If it happened yesterday, just ask that, any chance you skipped your meal before this happened? Because if patient skip their meal and then do a little bit of exertion, that can result in hypoglycemic attack even in a normal person. For vasovagal syncope, there is not much of a question that we can ask. The history will give us the diagnosis. In vasovagal syncope, you can ask one question, that was it like when this episode happened, were you in a hot, sunny environment? Were you sweating a lot? Or were you standing for a long time? Because in vasovagal syncope, if it is a hot, sunny weather, and let's say patient was doing gardening, or patient was jogging, running, doing exercise, or even playing, or maybe went for a racing of a marathon. So something exertional they have done that can cause this vasovagal syncope. Why? Because in vasovagal syncope, if they stand for a long time, there will be peripheral pooling of blood. So because of peripheral pooling of blood, all the blood is in your extremities. So the brain is not getting enough blood supply. So because of that, sometimes they can start to feel dizzy or lightheadedness, and then suddenly they fall, they lose their consciousness, and after a few seconds to minute, they regain their consciousness. So these are the vasovagal syncope scenarios. So were you in a hot, sunny weather? Were you doing any exertional work during that time? Okay, where you were standing for a long time. So those will be main thing that you are looking for. Postural hypotension. Postural hypotension is a condition where patient get dizzy or lightheaded, especially when they change their position from lying to sitting position or from sitting to standing position. So they were sitting for a long time, suddenly they stood up and then they lost their consciousness. That's postural hypotension. So you just ask the patient, do you feel dizzy, especially when you change your position? If they say yes, then ask in more detailed way that, does it mainly happen when you get up from bed in the morning? Okay, so that's your postural hypotension question. For anemia, you can ask, do you feel very tired and fatigued these days? Anyone commented that you look very pale these days? And then quickly ask, any stress at your home or work? Now, we normally don't get bothered with stress in a syncopal attack, but still, if you have some time, just ask this single question. So these are all your differential diagnosis questionnaires, and then you just finish it with past medical history, family history, and SADMA. Okay, so in the past medical history, just ask the question that any known medical condition like diabetes, high blood pressure, or heart disease. In SADMA, we just ask that smoking, alcohol, and medication history. So do you smoke or drink alcohol? Are you on any medication? If patient is on a particular medication, we are supposed to ask in detail that what are the medications you are on, any recent medication that has been added, or did you change any dose of the medication by yourself? What's the reason of it? Because it can be a postural hypertension. Maybe patient has increased the dose of an antihypertensive, or maybe the doctor started a new diuretic. So something must have caused it. So ask the medication history in detail. And lastly, just ask any family history of heart condition, any family history of sudden death due to any heart cause. Sudden cardiac death in family always is a risky finding. What normally you should think if there is a history of sudden cardiac death? Hookham, very good. And also Dr. Karishma and others, long QT syndrome. So these are the two most important things where you get this family history of sudden cardiac death. So prolonged QT syndrome, which has a familial tendency as well, and HOCM. So that's important finding in these cases. So that's how you're going to finish your history. After you have done it, thank the patient, and go to your next task. Okay, so to give you a summary of what we have done so far, in the history, you're going to first introduce yourself, greet the patient properly, reassure the patient that you are going to take care of him, and then you make sure patient is vitally stable in face-to-face. In online, you just say that you are going to check it. Then you start your HOPC. In syncopal cluster, we will divide it as pre-syncope, syncope, post-syncope. Then we go to the differential diagnosis, making sure we ask CVS, CNS question, then all the other questions, hypoglycemia, vasovagal, postural hypertension, anemia, and stress. And lastly, we finish with past medical history, family history, and SADMA. SADMA, no, there is a lot of things to ask, but we only just ask smoking, alcohol, and medication. What are these two? So D is for diet, A for allergies, which normally we don't need to ask every time. So is this clear for everyone, the history format? Any question? So Dr. Huria, you asked that are the vitals given in the STEM in online? Very good question. It can or cannot. There is no obvious thing like that. So even in face-to-face, sometimes vital can be given in the STEM. Same can happen in online exam. The good thing is that if vital is given in the STEM or in your question, then you don't need to ask it from examiner. And you should never do that as well. If you do that, again, it shows that you did not read the question properly. And examiner also don't like it. Can caffeine do that? Caffeine can cause arrhythmias, that's right, but it's not our first thing that we should think of. If it is a palpitation case, then yes, caffeine we can think of as one of the cause. Menstrual history. So it depends on the case. We will do some case, Dr. Nijatu. So especially if it is a reproductive age group female who comes to you with a sudden syncopal attack, yes, we are supposed to rule out that. And it's mainly for female in reproductive age group. In those cases, we will ask some questions related to pregnancy. Just when was your last menstrual period? Are you sexually active? Any chance you could be pregnant? Okay, because it could be pregnancy or it could be even some other complications of reproductive age group like ectopic pregnancy, etc. So prolonged standing or excess sweating, how it causes peripheral blood pooling, because this causes your vagal nerve stimulation, and vagal nerve is a vasodilator. And if it's causing vasodilation, all the blood actually pulls into your periphery. Okay, so that's the vagal nerve or vagus nerve causing all of this. What is the timeline for regain consciousness in vasovagal syncope? Usually less than 1 minute. Yes, Brugada's syndrome can cause it. Again, we don't need to be a cardiologist for this exam. Brugada's syndrome is for cardiologists who are going for a specialist exam, but this is a junior exam. We will not bother with that much detailed thing, okay? Do we need to ask bleeding for anemia? And also, do we need to ask vomiting, diarrhea? Again, Dr. Mariam, it case by case, because if we need to ask everything in the history, then you will never be able to finish your history and then do other cases. Our idea is if we get any specific finding, like if patient says that patient feels dizzy when they change their position, then we are going to find out what's causing this. We are going to ask more detailed question. Again, if patient says patient feel tired these days, then we will go in more detailed questions of anemia. So as a format, we are not going to ask everything because we can't finish it in time if we do that. So your idea is in differential diagnosis, only 1 or 2 questions for each of these causes. But it doesn't mean that this is the only questions that's there. If you get some positive finding, we are going to go in more detailed questionnaires, which we are coming in the cages. Okay, let's move on to physical examination from examiner. So you have done your history format. When you come to the physical exam from examiner, again, it is different from face-to-face and online. So the task will be different, right? So in face-to-face, most of the time, this is the task. After your history, then second task is ask physical examination finding from examiner, and examiner will give you the finding only that you are going to ask. So whatever you are going to ask, examiner will give you. Now, if you miss something, examiner will not give it to you. So physical examination from examiner is something that you just ask one by one questions from examiner, and examiner give it to you. You don't need to do it on a person because this is not a physical examination task. In online exam, there are two ways. One, that they can provide you a physical examination card on the screen where all the finding will be already given. You don't need to ask it from examiner. That's the most common one. The second most common one we have seen sometime that they ask you, explain the examiner that what physical examination you are going to do with this patient. And at the end of it, examiner will give you a physical examination card on the screen, which means that you are going to say everything that you are going to do. And after you have done it, examiner will show it on his screen. What are the findings that you have got? Okay, let's start with the face-to-face format. In face-to-face, you're going to say that, dear examiner, I would like to do physical examination on my patient, starting with the general appearance. Is he look comfortable or in distress? Examiner says comfortable. I would also like to check for any pallor, icterus, clubbing, lymph node, and dehydration. Now, we should not ask 5 or 6 questions at a time from the examiner. And it's not always everything in the pickle. So what is pickled, by the way? Pickled is a part of your general examination, which involves pallor for anemia, icterus for jaundice, C for cyanosis, K for clubbing, although clubbing is actually C, but still we keep it like this. L for lymph node, E for edema, and D for dehydration. So again, are we going to ask everything? No, we are only going to ask the relevant one. For a syncopal case, what is relevant? Pallor is relevant because it could be anemia. Then let's say that edema, dehydration is important. Dehydration can cause syncopal attack. If it is anything like a cardiac problem or renal failure problem, that can also cause this. So edema is also good. But others like cyanosis, clubbing, not very relevant in this case. Even icterus, not very relevant. Lymph node, we always ask it, so you can ask it as well. So you can just ask after general appearance that how about any pallor or any pallor, edema, or dehydration? Examiner says negative. Any sign of lymphadenopathy? Negative. I would also like to check the vitals. Now it depends. If examiner did not give you the vitals initially in face-to-face, then you are supposed to ask it in your physical examination. So again, blood pressure, pulse, respiratory rate, everything you are supposed to ask, and ask the BMI. BMI is not very important for a syncopal case, but I always keep BMI with vitals so that I don't forget, because there are some cases where BMI is very important to ask. So we have asked general appearance, pickled, vitals, and BMI. Then we go to the systemic exam. So say that I would like to do whole body systemic examination from head to toe, but first I would like to focus on the neck. Is there any raised JVP, any carotid bruit? So if you ask, is there any raised JVP? Examiner says no. Any carotid bruit? No. I would like to do cardiovascular system. On inspection, any visible cardiac impulse? No. On palpation, is the apex beat normal in position? Yes. Any palpable thrill or any parasternal hip? On auscultation, apart from S1, S2, is there any added sound like any murmur? Examiner says no. I would also like to do a full central nervous system examination, including cranial nerves. Examiner says all normal. Also, I would like to do all other systemic examination, including respiratory system and abdominal system as well. All normal. Is there any office test available, examiner? So what you are looking for, urine dipstick, blood sugar level, and the electrocardiogram. Now, coming to the office test. Office test is something which we also call as bedside test, which means that the test that you can do on bedside of a patient. Can you ask for an ultrasound or X-ray in office test? No. Although we know that we can do bedside X-ray, bedside ultrasound, but we are not supposed to ask it in the exam. We can only ask few, especially urine dipstick, blood sugar level, ECG if it is relevant, especially for cardiac cases, we are going to ask ECG. And others, case by case, sometimes we can ask urine pregnancy test. Sometimes we can also ask spirometry, especially if it is a respiratory case. Okay, so obviously not for this one. Urine dipstick, why it is important? For syncope, not very important, this urine dipstick, but blood sugar level is very important to rule out any possibility of hypoglycemia or even hyperglycemic coma or something like that. So BSL and ECG is the most relevant one. So if you don't ask urine dipstick, not a problem at all. So that's how we are going to ask physical examination from examiner. Okay, now why we are mainly focusing on a CVS? Why we are doing all others just with one sentence, but CVS we are doing in detail? That's actually the idea. In exam, you're supposed to do the most important systemic examination at the first. That means first you do the most relevant one. A lot of candidates, they start with head, that means first CNS, then go to the CVS, respiratory, abdomen, everywhere. Even if it is a respiratory case, they start with CNS first. That is also not a good idea. So we always say that your first physical examination should be the most relevant one. What is the most relevant systemic exam in a patient who are having syncope? So you start with the neck for JVP and carotid bruit, and then you go to the CVS. The CVS is the most important systemic exam. So that systemic exam, we are supposed to do in detail with inspection, palpation, auscultation. Okay. Now, every cardiac exam, we are going to follow the same. So inspection, visible cardiac impulse for any kind of valvular disease, even if it's a cardiac failure, if there is any other causes like constrictive pericarditis, pericardial effusion. So any cardiac causes that can cause visible cardiac impulse, we are going to find that. Apex beat, palpable thrill, parasternal hip. Now, these are all for palpable thrill can be because of if patient having any valvular disease, especially we are looking for aortic stenosis. Parasternal hip, palpable P2, especially for like right ventricular hypertrophy, we ask parasternal hip. Auscultation, the most important thing is murmur because again, aortic stenosis is one of our DD. Okay. And others are not very important. CNS we should do because one of our, like a few of our differential is CNS. And then other system, you don't need to do like this. You just say that you would like to do. And examiner normally says that it's all normal. Okay. So did you guys get an idea how to do it in face-to-face? So if full blood count considered a bedside test to assess hemoglobin level? No, only the ones that I have told, these are the bedside tests. Online exam, we are coming in a bit, Dr. Saba. Should we elaborate what we look in CNS exam? No, no need. Just say that you would like to do full central nervous system exam, including cranial nerve. Trust me, you will not get that much time in the exam to ask even what I have written here. So don't add anything more. Can we just say a line that I would like to do the rest of the examination? Yes, you can say. Okay, you can always say that I would like to finish with the rest of the systemic exam, including abdominal exam, respiratory system. Yes, we don't need to go in detail of the irrelevant system because abdomen is an irrelevant system for a syncope patient. So we don't need to go in detail of that. And Dr. Madiha, as I said, that this is a part of your theory case, right? This is not a physical examination case. So you don't need to do it on a person. This is actually a physical examination finding from examiner. So you ask it from examiner and examiner give it to you. There are cases where you have to do it. Those are different. Those are physical examination case only. There you don't need to take any history. Your only task is do physical examination on this patient, give running commentary on the when you are doing it, an examiner will give the finding to you. So that's a total different thing. We will do that later on, not now. We already checked edema, right? In here, in pickle, Dr. Anna. Please discuss online format more as upcoming. Yes, we are doing it. Just give me a time. So in online exam, what we are going to do. So for online exam, because examiner doesn't give you anything. So most of the time, examiner will give you all the findings on a card, and that will be given on your screen. So everything, general appearance, comfortable, no pallor, no icterus, vitals will be given. So everything will be given on a card, and you just read it. And after reading it, your next task will be to discuss your diagnosis and maybe management or differential diagnosis with the patient. All right. The second task which can be is that discuss what physical examination you are going to do with your examiner, and after that a card with the finding will be given on the screen. For that particular case, we're going to say in this way. So because examiner doesn't answer, you're just going to say everything that is written here, but you're not going to wait for the examiner findings. So you will say that, dear examiner, I'm going to do physical examination on my patient, first starting with checking his general appearance to see if he looks comfortable or in distress. Then I'm going to check for any pallor, dehydration, lymphadenopathy or edema. I will take his vitals starting with blood pressure with a standing and sitting position, rate and rhythm of pulse, and then temperature, respiratory rate, and oxygen saturation. Then I will going to check his neck for any raised JVP or carotid buoy. After that, I'm going to do a focused systemic exam on cardiovascular system. First, I will start with an inspection for any visible cardiac impulse. Then on palpation, I would check his apex beat position, any palpable thrill or parasternal hip. Then I will do an auscultation and look for any other added sound like any murmur. After that, I will do a full central nervous system exam, including his cranial nerve, and finish with all other systemic exam. And then I will also look for any available office test, especially for any blood sugar level and ECG. Thank you, examiner. After that, examiner will give the finding on a card. Okay, this is the only difference between online and face-to-face. As you can see, it's just the way of the exam. The thing is same. That means the preparation is same. It's just the way of exam, which is a little bit different. Is this clear for everyone? Great. Let's move on to a case, aortic stenosis. So now we are going to do cases one by one. Now that in your head, what I would like you to think is all the differential diagnoses that we have done so far, and then focus on the physical examination that we have done. We are just using the same history, same physical examination for rest of the class. You'll see how we do that. So you are a GP and your next patient is a 52-year-old male who is consulting you about the recent loss of consciousness. Your task is to take a focused history from the patient. Now, this task is actually from face to face. In online, it will be a little bit different task. So take physical examination from examiner, ask for necessary investigation from examiner, and give your diagnosis and management. Most of the time, the task will be history, physical exam, diagnosis, and DD. In online exam, because most of the time they don't ask you to do physical exam, they also ask for management in online. In my experience, in online exam, there are more tasks than face-to-face. I don't know why, but that's how I always see that there is a lot of tasks in online exam, rather in face-to-face, the number of tasks is a little bit less. So patient 52-year-old had a recent loss of consciousness. So when you look on that part, you know that this is a syncope cluster. So in the 2-minute outside, you think about what are the differential diagnoses that I'm going to ask here, how I'm going to start my history. So you just think in your head that how are you going to do this case? If you can do that, it becomes very easy when you go inside the room. Okay, same in online exam. In the 2-minute outside, please make sure you don't write anything on the paper. When you go in, that means when your 8-minute time starts, even if you want to write something, you can write it. But in the 8-minute time, you are going to just make sure you finish all the tasks that has been asked. So when you ask all the history that we have done, the positive finding that you're going to get in this case is that patient was playing tennis with a colleague and then started to black out. That happened only once yesterday. And also for the last 2 months, he is experiencing this shortness of breath, especially during exertion. Also sometimes get chest tightness or chest pain. So aortic stenosis is a triad of chest tightness, especially on exertion, plus shortness of breath on exertion, plus syncope. So that's the triad of aortic stenosis. In the physical exam, you do same thing that we have discussed, but when you come to the auscultation, you will get some finding. So this is a valvular heart disease. So for aortic stenosis, you get an ejection systolic murmur in the aortic area, which radiates to the neck or carotid. You can also get apical impulse, displaced and forceful. So these will be your finding that you're supposed to get in this case. So apical impulse is displaced with an ejection systolic murmur in the aortic area, which radiate to the neck. Now coming to the point, if it is a face-to-face case, when you ask to the examiner that any murmur, examiner says, yes, there is a murmur. Are you going to stop there? No. You are supposed to ask more detailed questions. So you should ask that examiner, I would like to know if it is a systolic or diastolic murmur. Examiner says it's a systolic murmur. So we know that systolic murmur, either it's a pansystolic murmur or it's an ejection systolic murmur. So ask the examiner, is it ejection systolic murmur or pansystolic murmur? We know that pansystolic murmur is usually mitral regurgitation murmur, right? So an ejection systolic murmur is aortic stenosis murmur. So if examiners say ejection systolic murmur, then immediately you think about aortic stenosis. We also know that aortic stenosis radiate to the neck or carotid. So ask the examiner, is there any change of this murmur with respiration or change of position? No. I would also like to know if the murmur radiates to the axilla or neck. Murmur that radiates to the axilla is mitral regurgitation murmur, and murmur that radiates to the neck, that's aortic stenosis murmur. Okay, So that's how we are supposed to ask detailed questions in face-to-face. But in online, most of the time, they will give this on a card and it's not very hard. So once you have done your history and also you got your physical examination finding, you are supposed to get your diagnosis by that time, right? So once you know the diagnosis, next is explain the condition and management. So how we are supposed to explain this to a patient? So we will say, thank you so much, John, for waiting, and thank you for all the information that you have provided. Now, from the history and physical examination, most likely you are having a condition called aortic stenosis. Do you know what it is? Now, coming to this point, that a patient who has got aortic stenosis, they don't know what is that. And if you use medical jargon without explaining that, that actually is not a good idea. You are supposed to always explain any medical jargon that you are using in the exam. An explanation should be non-medical, should be very simple way so that a patient understands you. Okay, so again, when you ask history from the patient, you can't use any medical jargon. You can't say that, does your pain radiate to anywhere? Patient might not understand what is a radiating pain. You can't ask a patient that, have you got any murmur? Because patient don't know what is a murmur. So just make sure that don't use any medical jargon with a patient, especially in your history. And when you explain the diagnosis, obviously diagnosis is a medical jargon, but you are supposed to explain it in a very simple way. In face-to-face, we should draw so that patient understand more clearly. In online exam, we can't draw because patient will not even see what we are drawing. So don't bother with drawing in online exam. So what we are going to say, so most likely, we never say that definitively you are having a condition called aortic stenosis. As a junior doctor, we will always say most likely. So from history and physical exam, most likely you are having a condition called aortic stenosis. Do you know what it is? No, doctor. Well, let me explain it in detail. So let's say we're doing online. So you can say that, well, you have your heart on the left side of your chest, and your heart has 4 chambers. So drawing is very, very easy to explain, but if you can't draw, then you just need to explain it. Either you can use your hand to show the heart. So somewhere you should make sure that patient understand what you are saying. If you can't do that, just explain in a very simple way. So we have got our heart on the left side of our chest, and our heart has got 4 chambers. 2 chambers are upper chamber and 2 in the lower chambers. Each of these chamber has got a door-like structure known as valve. In your case, the valve that controls the flow of blood from your heart to the big artery known as aorta that supply blood in our whole body, that is narrowed. The valve that we are talking about is known as aortic valve. Are you with me so far? Yes, doctor. So that's why the blood supply to your brain is also reduced, which causing this loss of consciousness. And when you exercise, the demand of oxygen from your hearts get increased, but your heart valve is already narrowed and it can't supply enough blood. And that causes the chest pain and shortness of breath, especially when you are doing any exertion. Are you with me so far? Do you understand what I'm saying? Yes, doctor. So see that how simple it is to understand. So we have our heart on the left side of the chest. Our heart has got 4 chambers, 2 upper, 2 lower, and each of these chamber has got a door-like structure called valve. In your case, the valve that is supposed to control the flow of blood from our heart to the aorta, which is the biggest artery, which is supplying all blood in our body, is narrowed. This valve is what we call as aortic valve. Are you with me so far? Yes. So that's why the blood supply to your brain gets reduced, causing this loss of consciousness. And when you exercise, the demand of blood and oxygen is very high, but your valve is already narrowed and it cannot supply that amount of oxygen, which causes this shortness of breath and chest pain, especially when you are doing any kind of exertion. Do you understand me so far? Any questions? No. So in that case, I always say that in your exam, the best idea is to make sure that patient understand why the patient is getting the symptom. Now think you or your relative as a patient. If you don't understand why you are getting loss of consciousness, explaining aortic stenosis doesn't make any sense. If you just explain that, well, aortic stenosis means one of the heart valve is narrowed, and that's it. You haven't said anything else. What patient has got from you? Nothing. You just did a job, but you actually did not say the most important thing to the patient. That means why I am getting loss of consciousness, doctor? Why I feel chest tightness when I am playing tennis? Why my other colleague is playing better than me, right? So that question should be answered with your explanation. Always correlate your explanation to the patient's symptom so that they understand the reason of this symptom, and then they get involved with your management. Otherwise, they don't even bother, like, well, I will stop playing tennis, that's it, right? So what I always say, this is actually the way. It's not just to pass your exam. This is something that you are going to use in the rest of your life when you are practicing in Australia. And patients love it, okay? So please make sure that you start doing this even in your day-to-day life. Now, the next part is that sometimes it's a good idea, even differential diagnosis is not a task. I say that if you get some time in the exam, say some differential diagnosis as part of your explanation. So say that it could be due to other causes as well. Like it could be some other structural heart defects, but it's unlikely in your case. It could be due to some brain-related causes, like a stroke, but you don't have any weakness in your body, so it's unlikely. Could be head injury, but you haven't injured your head recently. Could be epilepsy or seizure, but you did not have any jerking movement. So there is a lot of other causes of having this similar kind of symptom, but in your case, those are very unlikely. So please don't get stressed about it. This is not a very unusual condition, and it's one of the common cause of loss of consciousness in your age group. What I'm going to do further is that I'm referring you to the hospital to confirm my diagnosis and to rule out other diagnoses. In the hospital, they will do some investigation such as full blood count, inflammatory marker, your liver kidney function, an electrocardiogram of your heart, chest x-ray, and an echocardiogram, which will confirm this heart valve defect that you have got. You will be also seen by a cardiologist who is a heart specialist, and further treatment will be based on the degree of narrowing of the blood vessel and the severity of your condition. Now, this actually depends. A lot of time, if it is a GP clinic, for aortic stenosis, you don't need to straight away send the patient to the hospital if the patient seems stable to you. Only time you will send the patient to hospital if this patient looks unstable, if the vital is not good, or ECG having some changes, then you can send the patient to hospital. Otherwise, what you can do that you can start doing some investigations. That means all these investigations you can also arrange. And once echocardiogram is back, then you can refer this patient to a cardiologist in the hospital, and they can see the patient in the outpatient, and they can manage the patient accordingly. So there are two ways to manage aortic stenosis. If patient is stable, you can say that, well, first of all, I would like to do some investigations, including this blood test, ECG, chest x-ray, and then echocardiogram, which is basically just a scan of your heart, and that can confirm the degree and severity of this valvular heart defect that you have got. Once I have got all this report, if it confirms my diagnosis, I'm going to send a referral to a cardiologist who can see you further to manage you accordingly. The management can be based on how much is your symptom and the severity of your condition. If it is a severe narrowing of your aortic valve, most of the time, cardiologist can go for a replacement of the aortic valve, and that will be discussed in detail by your specialist. Okay, so that's usually the management of aortic stenosis. If it's not a severe narrowing of the heart valve, in that case, it's just conservative approach, wait and see, and making sure every 6 to 12 months, patient will have an echocardiogram to see that if it is getting any worse. So that's your aortic stenosis management. So see that this is exactly how we are going to explain a condition. It always depends what is your task. If your task is give the diagnosis and differential diagnosis to the patient, you will not discuss about any management. You will just give the diagnosis, explain the diagnosis, and give the differential diagnosis. But if management is a task, then you are going to say these lines. Okay, let's have a look to your questions now. So face to face, Dr. Lulu, we need to ask one by one question. Yes, one by one questions, and then the examiner is going to give you the finding. If we can't reach correct diagnosis, Dr. Fatima, yes, the station will be failed. What about thrill, Dr. Mariam? I discussed. You can ask the thrill. Sorry, doctor, you mentioned one of the examiner response is stick to your task. Does it mean we assume patient is stable? No. Stick to your task means examiner doesn't want to give the finding right now. They will give you during the physical exam. So if they say stick to the task, it means that you go on with the history during physical exam, ask this vital again, and I'm going to give it to you. Is it okay to draw a picture on paper and show it through camera during online exam? Dr. Misha, it is okay if you can, but if you actually do that, when you use it on a camera, most of the time, the image will be like a mirrored image. So what you are trying to show, the other person on the video, they would not be able to understand that. So I say that it's not actually needed. It can just waste a lot of time in the exam. Now, artery, blood vessels, again, we can use a little bit of medical jargon because we are explaining most of it. When we are saying blood vessel, patient should understand what is blood vessel. If they come back to you and say, doctor, what is blood vessel? Then you can use the term blood pipes. They understand blood pipes better than blood vessel. Okay, but a lot of Australian, they actually understand blood vessels. Artery, vein, they might not understand. The thing is that when you explain something, the other person who is listening to you, it should be also, they should actually feel that it's a good explanation. If you need to explain the medical jargon, explain it in the next sentence, like I did when I said that the flow of blood from your heart to the biggest artery of our body, known as aorta, is getting narrowed. Then I said, and the valve in here is known as aortic valve. So you can always use multiple sentences and then explain your medical jargon. But if you try to explain everything in one sentence, it's just like a very haphazard thing. I would say not to do that. You can always explain what you have said. If you said artery, you can say that artery means it's the blood pipes that supply blood to our whole body. It's easy. Should we explain to patient at every station, or it will be given a task? It will be given as a task. We only explain what is given as a task. Good question, Dr. Anna. If they ask us that for differential diagnosis, Are we supposed to say that why this differential diagnosis is unlikely? Yes, it is a good idea. As I have said that it could be a stroke, but you don't have any weakness, any vision or speech problem, so it is unlikely. That's the best way to do it. Can you please repeat when we have to manage in detail and we don't need to refer? Okay, so Dr. Iman, the management only needed if it is a task. If in the task they say diagnosis with management, then you are going to manage. If patient is stable, you don't need to refer this aortic stenosis patient to a hospital. You can do everything. And after getting the echocardiogram result, you can refer the patient to a cardiologist. If it is an unstable patient, then you should refer this patient to hospital. Chest X-ray is not essential, but it's a part of a basic examination that we can do. Because if there is any kind of heart failure or anything, chest X-ray will give us some finding. Okay, it's not mandatory, but as part of the examination, we do it. In case where they ask diagnosis, if we tell DD saying unlikely is okay rather than giving only one. Normally, we are supposed to give the most likely diagnosis first rather than giving all the diagnosis, because that means you don't know what's the diagnosis. Ideal is you should give the most likely diagnosis first and then give the differential. If examiner says stick to the task, it's not an indication of failing that task. No, it means that examiner will not give that finding to you now. It's totally fine. No problem with that. If task given diagnosis and DD, then it is wise to explain diagnosis, then first enlist DD, then explain why not the individual disease. Yeah, all of these questions will come one by one. Let's not think that we are going to like finish everything in our single class. That will be like, that's not possible. I know a lot of questions are happening in your head, but this will come again and again, especially thinking about it. When you do the role play with us, I will show you what to change, because we always change things based on the task. Especially if you are running out of time, we say that you first give your diagnosis, explain it very fast, give the name of the differential diagnosis, and still if you have some time, then explain the differential diagnosis, why it is unlikely. That's actually the best idea if you think that you are running out of time. Okay, because then at least you have told the differential diagnosis and they can mark you. If you haven't said your diagnosis or DD, the examiner can't mark you in that task, and likely chance you're going to fail. All right, guys, that's it. Let's take a 5-minute break now, and then we are going to finish the syncopal cluster. Okay, not 10 minutes, we are going to take a 5-minute break. Thank you. All right, everyone, let's start again. So we have done aortic stenosis, the first case of our cluster. Next is prolonged QT syndrome. So prolonged QT syndrome is a part of arrhythmia, but it also comes in the exam as syncopal cluster. So you have got a 19-year-old girl comes to the ED because she fell unconscious 2 days ago while she was climbing up in a mountain. When you read a question in the 2-minute outside, few things you should focus. One, that what's the age of the patient? What's the sex of the patient? Where are you at the moment? Are you in the GP clinic or are you in the emergency department? What's your role? Are you a register? Are you a HMO or JMO? So what's your role? Most of the time, you are a HMO in the exam or a RMO, same. Okay, that means junior doctor. And then find out what's the main presentation. Okay, so that's how we read the question and then we think about, then we look at the task. So how many tasks I have got? History, physical exam, investigation, diagnosis. So if it is a 4 task, I need to be more fast in the exam. If I am slow, likely chance I would be only able to finish up to this. Okay, so you have to cut your history a little bit. So that means you can't ask everything in the history, just the relevant ones. Then quickly come to the physical exam, investigation, diagnosis, and management. If it's a 2 task, that means you have a lot of time. So history, you can ask everything. And you are supposed to ask everything if it is a 2 task, like history, give your diagnosis and differential. In that case, history should be more detailed, like at least 6 minutes, and then diagnosis DD for 2 minutes. When there is a 4 task like this, if it is an online exam, then usually the task will be history, physical examination on card. That means it will not take a lot of time. And then they would not ask investigation from examiner. They would say that ask for appropriate investigation from examiner and explain it to the patient. So that's your hard task. If you can ask the appropriate investigation, examiner will show it to you. And then they will ask you to either explain that to the patient or explain it to the examiner. And the last task might be diagnosis DD or diagnosis with management. Okay, so what we are supposed to do, the best idea would be 4 minutes in history, 1 minute in just by reading the PFE card, even if you can, just 30 seconds. If you can make it like we usually, investigation from examiner and explain it to the examiner 2 minutes, diagnosis and DD 2 minutes. Still you can't finish it. Okay, so what you will have to do, make it as 3 minute history. So see that history time is getting smaller. Okay, so in that way you would be able to finish your exam in the appropriate time. The likely chance that history might go up to 3.5 minutes, and just by reading the card, some people can read it in 10 seconds. So it will not take a lot of time. So you'll need to manage the time accordingly. Okay, so the idea is that if tasks are more, the history will get smaller and the examiner will not fail you for that because they are aware that you can't ask everything because you have a lot of tasks. So the findings in this case is a 19-year-old girl got loss of consciousness while climbing a mountain. So patient usually gets sudden loss of consciousness. 3 episodes so far. Different things each time. No shortness of breath, chest pain, palpitation. History of unknown heart disease in maternal uncle. That's your most important finding. Apart from that, in physical exam, there is no murmur. But when you ask for investigation from examiner gave you a ECG. And the ECG will give you the finding of long QT syndrome. Okay, so the only way to diagnose it is to look at the ECG, and there is no other way. So history will not be able to give you the diagnosis. So most of the time, if this is the case, they are going to provide ECG in the exam. So how to read that ECG in the exam? That's another tricky part. We are going to do more ECG in our next class, but today we will just touch the point. All of you should have a basic idea on ECG because you have passed MCQ, and MCQ needs you to know ECG. So I guess you have the basic idea. So normal ECG means this is, all of you know that this is P wave followed by QRS complex and then T wave. We have got PR interval, then the QRS complex, and then QT interval is the important one in here. So QT interval means starting of the Q wave, so from here, and end of the T wave. So that's your QT interval. In a normal person, in men, we normally say that normal QT should be between 8 to 11 small square. Okay, that's the easiest way to remember, and we only focus on that. We don't focus on how many second or millisecond is the QT. Okay, so sometimes in ECG, when you actually do it, you can see the corrected QT on the ECG paper, but in exam, they might not provide that to you. So in that case, the only way is to know the normal QT interval, which is 8 to 11 small square. Now, you might be thinking, how am I supposed to read a ECG in that 2-minute time and then again explain it to the examiner? How am I going to do that? The way is being smart. You can't do everything. Being smart is the only way to save some time. So you know that this patient having syncope, having a maternal uncle who had got sudden cardiac death. In your mind, you already know the diagnosis, which means it's likely to be a prolonged QT syndrome. It's not a MI because patient did not present to you with chest pain, and it's a 19-year-old. So I'm not going to look at like chest lead for ST elevation, right? I'm not going to look for any other like atrial fibrillations or anything like that, because if it is atrial fibrillation or supraventricular tachycardia, patient would come to you as palpitation. So in your head, you are supposed to already know a diagnosis and then exactly look on that on the ECG just to confirm it. So if I were you in the exam, I would actually look at the long lead, which is the lead 2, and we will quickly look at, let's say this is the P wave, then we have got QRS complex and T wave. Then I will quickly check what's the QT interval looks like. So that's the Q. And if I say that this is the end of T wave, so basically in here there are 5 small square, then another 5, 10. Then we have got another 4, so 14, at least 14 to 15, right? Small square. So already we understand that it is more than 11. That's a prolonged QT syndrome. That's it. I'm not bothered with anything else. Quickly, I will check the other things. So I will look at V1 to V6 for any ST changes. I would look at lead 1 and other limb leads for any changes. That will be the smartest way to look for anything on the ECG. Same when we get a palpitation case, we know that in our head, it's either a SVT case or it's a atrial fibrillation or flutter case. Because in exam, they would not give you a ventricular fibrillation patient, right? So being smart in the exam also one of the way, okay? Because you actually will not diagnose this patient in 10 minutes in your real life. You will take more time, but in exam, you don't have that time. So you have to be smart so that you can finish it in finish in time at least. When we will discuss the chest pain cluster and palpitation cluster, I will go in more detail about this ECG reading, not today, okay? So just make sure that you know how to diagnose it and how to explain an ECG to the examiner. We will discuss in our next class. Just keep that thought in your head. So once you know that this is a QT prolongation, next task is to explain the diagnosis. So explain that most likely from history, physical exam, and the ECG, you are having a condition called prolonged QT syndrome. Do you know what it is? No, doctor. Well, we have done an electrocardiogram of your heart, which is a recording of electric activity of your heart. So, again, if it is a face-to-face, it's very easy to draw. If it's not face-to-face, then online, it's a little bit difficult. The idea is that you explain it in a very simple way. So say that, well, when the nurse put those leads on your chest, we actually recorded your electrical activity of your heart. These electric activity are supposed to help your heart to pump the blood to your whole body. Now, this ECG that we have done has different parts, which represents different components of this electric activity. In your case, the part that we call QT interval is markedly prolonged, and that is why we are calling it as a prolonged QT syndrome. This condition is associated with abnormal heart rhythm, resulting in impaired pumping of blood, and that causes frequent collapse, like in your case. Because your heart needs to pump enough blood to your body, especially to your brain. If it cannot do that, your brain gets lack of oxygen and blood, and that's why you're getting frequent loss of consciousness, especially when you're doing something exertional. Are you with me so far? Do you understand what I'm saying, John? Yes. Now, it could be due to other condition as well. So give all other differential diagnosis, and if you have some time, say why it is unlikely. Most of the time, this case doesn't come with management because already it's a huge task. They usually give the task as diagnosis and differential. So it's easy. In case of management, you should always say that, please don't get scared. It's not an uncommon condition. Sometimes this can run in the family. Sometimes it can be due to some medication, dehydration, or salt and water imbalance. Unfortunately, left untreated, this can cause serious consequence. That's why I need to admit you to the hospital and call the cardiologist or heart specialist to review you. Please don't worry, you are in a safe hand, and we will do our best to manage your condition. See these reassuring sentences. These are the ones that are going to pass you in the exam. A lot of time, first-time candidate don't bother with reassurance, don't bother with like thinking that this patient actually needs some reassurance that I'm not going to die out of this condition. Okay, so that's a very important part of management. The specialist might do few investigations, starting with your blood test, especially full blood count, your kidney function, blood sugar, and ECG and the echocardiogram. Explain that echocardiogram is basically just a scan of your heart to see that if there is any other valve issues or any structural defect in your heart. In terms of management, it depends on all the investigations that he is doing. And he might start you with a medication known as beta blocker. If that fails, he might need to put you on some cardiac pacing as well, so that your heart, so that you don't get into any serious heart arrhythmia or rhythm disturbance. And this pacing sometimes can make your rhythm come back to normal. If all the investigations come normal and we can't find out any cause, then we call it congenital prolonged QT syndrome, which means it's basically running in the families. And it might be also in your case because you know that there is an unknown case of sudden cardiac death in your family. In that case, a specialist will recommend all other family members to have a screening for this condition. Once you are discharged from the hospital, I will write a letter to your GP and he will follow you up regularly. Do you have any questions? Okay, so that's the management for this. Now, the thing is that, as I say, that management usually doesn't come in this case. So please don't get too much bothered and don't waste a lot of time for management. Rather, mainly focus on how to take a history, how to read the ECG and explain the diagnosis properly. Diagnosis is explanation. So your task will be diagnosis and management. So that's your explanation, Dr. Iman. So task doesn't need to mention, explain it to the patient. Okay. And also one thing that if in exam, everything will be very clearly written, that history from the patient, ask physical examination finding from examiner, ask investigation from examiner, explain diagnosis and management to the patient. So everything will be very clear cut in the exam. Okay, so you don't need to bother or think that who I am going to take history from examiner or from patient. If it is not written, always assume history should be from the patient and explanation of the condition should be towards a patient. Now, you might be thinking that, do I need to explain all the ECG to the patient? No need. Please make sure your patient is a very, very normal, usual person who doesn't care about your ECG. He or she just wants to know why I am getting loss of consciousness. And if you can just explain that, they will be happy. You as a doctor also not supposed to teach ECG to a patient. A lot of course, a lot of notes, you will see that they have written a lot about ECG. Does the patient actually needs to know that? No. And if you do that, patient will lose you. They might start sleeping and snoring in front of you. Same examiner. Please don't do anything like that. Keep it simple. Moving on to the next. So next case is postural hypotension, which is also part of syncope cluster. So far, you might have understood that we are not asking any history or physical exam. We are just talking about the management. That's the way of doing cluster-wise theory. Okay. You as a doctor, Dr. Harris, we expect you that you know what the management is going to be. At least you should say something. If you just say that I'm going to refer you to the specialist and then they will manage you, that's not ideal. You're supposed to explain a little bit, at least like what could be the medication, what could be the management. Obviously, you're not going to talk about the full surgical management, at least the name of the surgery, at least something relevant to that management you are supposed to say. Postural hypertension is a very important case for exam. So a middle-aged woman comes with dizziness for the last several days. So that could be one question. Or a 65-year-old male comes to see you because he had a fall yesterday. Your task is to take history, physical examination from examiner, diagnosis, and DD. So this is again 65-year-old had a fall. If you ask more, you will find out that he also lost consciousness. So what will be the positive finding in here? In this case, when you ask that, do you feel dizzy or lightheadedness when you change your position? Patient will say yes. At that time, you know that this is a case of postural hypotension. So you go in detail to find out what's the cause of postural hypotension. There is always a cause. Either it's the medication or patient might be having sepsis, infection, vomiting, diarrhea. Something is causing loss of blood volume. So once you find that patient feels dizzy, especially when they change their position from sitting or lying position, then you move on one by one. Find out what's causing it. So first of all, you can find out that any recent diarrhea or vomiting. So ask about diarrhea, vomiting. Ask about, are you bleeding from anywhere? Have you noticed any blood in your urine or stool? Ask in detail about the medication. So when you find out patient is on some medications, find out what are the medications you are taking. Is there any new medication you have started or any recent change of any medication? You might find out recently the specialist started a diuretic for this patient, or patient might say that one of the blood pressure medication I might have taken 3 of those medication by mistake yesterday. Or my doctor recently increased the dose of this medication. So something has triggered this postural hypertension. So very commonly you will get this finding in the exam. So it's usually medication induced most of the time in elderly patients. So polypharmacy and most commonly antihypertensive medication are supposed to cause it. Many times you can find that this patient might be diabetic also. So if it is a diabetic patient, find out a detail about the diabetes. So how long you are having diabetes? Is your diabetes well controlled? If yes, when was your last HbA1c and what was that? Are you regular with your specialist? Are you on any medication for it? If yes, what kind of medications you are taking? If patient is on metformin, that's fine. But if the patient is on insulin, then you might be thinking that it could be a hypoglycemic attack as well. So you might need to go in detail about it. We will come to that in the next case, that how insulin can cause fall in a patient. So my basic thing is that you need to go in detail, find out what caused this issue to the patient in the first place. So one by one, we are supposed to go in detail. Now, many times a patient can get postural hypertension with diabetic autoneuropathy. So sometimes with diabetic autoneuropathy, patient has some other features, like they get heartburn, they get bloated feeling in their abdomen all the time, they can get diarrhea, they can also get sexual dysfunction. Okay, so ask the patient that how is your diabetes? Is it well controlled? Have you noticed any complications of diabetes, like any vision problem, any change in your sensation in your foot, especially any numbness, tingling sensation in your foot for peripheral neuropathy? And then you can ask about autonomic neuropathy questions. So any heartburn, any bloating in the abdomen, any indigestion feeling. If there is a case, then chance that it might be just a presentation of diabetic autoneuropathy as well. Okay, so mainly find out few things. One, that if the patient having any recent vomiting, diarrhea, any bleeding from anywhere, find out the medication in detail, especially find out about diabetes and its complications. After that, you finish with everything and then you come back to the physical exam. In the physical examination, everything will be normal except when you ask the blood pressure in standing and sitting position, you will get postural drop. The postural drop, how we actually confirm it. So if you do a systolic blood pressure and diastolic blood pressure, if sitting is, let's say, 130 and diastolic is 80, and when the patient stands, it becomes 110 by 80. So we say that if systolic blood pressure falls more than 20 or diastolic blood pressure falls more than 10, any of these, that's postural hypotension. Okay, so systolic blood pressure dropping more than 10 when they stand from a sitting position, or diastolic 10. That time you can confirm that this patient has got a postural hypotension. So that will be the main finding in this case. The cases that can come in exam, especially the finding that you can get, one, patient was sitting in a chair, while standing from sitting position, patient collapsed. So that gives you the finding that when patient changed the position, this happened. The another question might be patient was taking risperidone for psychiatric problem and now coming with dizziness. Risperidone is a common medication to cause postural hypotension. So if they recently increased the dose, or even with recent introduction of this medication, patient can present to you with postural hypertension. So the main finding is finding out the cause of this postural hypertension, not just diagnosing a patient with postural hypertension. So explain to the patient that most likely the reason that you had a fall is due to a condition called postural hypertension. Do you know what it is? No, doctor. Well, this is a condition in which there is a sudden drop of blood pressure when you change your position from lying or sitting to a standing position. It could be due to many reasons like severe vomiting, diarrhea, high fever, strenuous exercise, but in your case, most likely is due to the multiple medications you have been taking. Also, as you are diabetic, it could be due to another condition called diabetic autoneuropathy, which can manifest as heartburn, bloating, diarrhea, constipation, difficulty in passing water or urine, and sexual dysfunction. But as your blood sugar is well controlled, it is less likely. This could be due to other reasons like heart rhythm disturbance or structural heart disease. Even sometimes can be a presentation of heart attack, but you don't have any chest pain, difficulty breathing or palpitations. Could be a stroke, but you don't have any weakness in your body. Could be seizure, but you did not have any jerky movements of your body. You did not bite your tongue, so it's unlikely. And so same like that, give all of the differentials. As part of the management, we are going to do some basic investigations, starting with your full blood count, inflammatory marker, liver and kidney functions, your blood sugar level, and an electrocardiogram to rule out any heart-related cause. If we get any findings from your blood test, then we will manage you accordingly. And also we will consult with your specialist to review your medication so that we can change or reduce the dose of this medication. Okay, so that's how we are supposed to manage this case. Most of the time, this case will come as diagnosis with reason, which means you need to give the diagnosis first, and reasoning should be why the patient has got it. So give all the possible reason and then say that in your case, it's most likely polypharmacy, which means multiple medication. If you get any specific finding, like patient increased the dose of a medication, or recently a particular medication has been introduced, like a diuretic, just explain that in your explanation that this might be the reason. Okay. Management usually doesn't come in exam in here. Same with the risperidone case, explanation is pretty much same. So just read it in your own time, it should be fine. Let's move on to the next case, which is vasovagal syncope, a very important case for exam. Before that, do you guys have any question? No, Dr. Shen. So Dr. Chen, you will not fail if you don't find out the cause of long QT syndrome. It's fine. As long as you say it's long QT syndrome, you are good. That's a tricky question, Dr. Iman. Many times they give you the brand name of the medication in the exam. So the idea is that if it is a brand name, they're giving it to you. If it is a face-to-face exam, you can ask the generic name from the examiner. Okay, but many times, if it is an online exam, they will give you the generic name. So furosemide, or like if it is a diuretic, they can say hydrochlorothiazide, furosemide, those kind of things. Yes, so as part of management, Dr. Huria, we are supposed to show the patient some of the findings. So that's what we have written in here, that what we can do for postural hypotension. There is a 30-second rule that we follow in postural hypotension patient. We say that when you get up in the morning, sit up slowly and stay for 30 seconds. Put the legs over the side of the bed for 30 seconds and slowly get up. And then you walk. So that means don't just stand up immediately after waking up. First you sit, stay for 30 seconds, then hang your legs down, stay for 30 seconds, and then slowly stand up. So that's, if a management coming in the exam, then you will need to say this line. A lot of things are given, take medication regularly, have a routine. If you forget to take a dose, take it in the next few hours. Don't double the dose. Lots of other things that we say. Again, we don't need to explain, Dr. Pramodia. As part of clinical preparation, I am only going to explain what you really need to know and what you really need to explain to the patient. Pathophysiology of risperidone causing postural hypertension, it is not relevant for your patient. Lots of medication can cause side effects. We are supposed to say that risperidone is one of the medication which can cause change of your blood volume, especially it can cause this change of your blood pressure, especially when you change your position. That's the only thing that we can say. We are not supposed to explain the pathophysiology of this condition, which is also not very well understood. Like the migraine case, we are not supposed to say what's the pathophysiology of migraine. No need. As long as we can say what is postural hypertension, we explain it properly, and we say that in your case, most likely reason is the risperidone, which is a medication. Sometimes as a side effect of it, it can cause this sudden drop of your blood pressure when you change your position. Sometimes it could be just the usual dose which can cause it, or sometimes if you take more than usual dose, that can also cause it. Okay. How can we differentiate syncope and dizziness? Dizziness will not have loss of consciousness. Whereas syncope, the term means patient has to lose their consciousness to say it's a syncope. But syncope, dizziness comes under the same cluster. We always say that if the patient coming to you with just dizziness, it's not a bad idea to explain some peripheral cause of dizziness. What is the peripheral cause of dizziness? Some ENT cause, which means if it is a relevant patient, we can ask few ENT questions. Especially we can ask that, have you like any vertigo-like feeling? Like, do you think that you are rotating around the environment or your environment is rotating around you? So if something like that happening with you, any ear pain, ear discharge, any loss of hearing, any ringing noise inside the ear. All right, because sometimes that can also cause dizziness in a patient. So any blocked feeling or any heavy feeling in your ear. So what can be the ear ENT cause of dizziness? It could be labyrinthitis. It could be benign positional vertigo. It can be Meniere's syndrome, acoustic neuroma, but everything will be covered just by these few questions. So ear pain, ear discharge, hearing loss, vertigo, then ringing noise, even sometimes you can say any loss of balance. That's it. And when you come to the physical exam, just you need to make sure that you want to check the ear, nose, throat, and also hearing. Now, we are not going into that because we are going to cover that in some other cases. Okay. But if dizziness is the main presentation, we are going to use the same syncope cluster, but as part of our differential diagnosis, we will add the ENT causes. Okay. And Dr. Eni, when we take history, differential diagnosis needed to be ruled out, even if we can get a positive finding. So if you get a positive finding of postural hypertension, you will ask the detail to find out the cause of it. And also you are supposed to ask a few differential diagnosis questions as well. So it doesn't mean that you have got a positive finding and you will not ask any other DD in the history. Moving on to vasovagal syncope. So it's an 18-year-old girl fainted during marathon and now fully recovered, but mother came to consult you. So it's an 18-year-old girl who fainted during marathon, and it was just like an annual sport, but now fully recovered. Mother came to consult you. It could be the mother, could be the patient, 18-year-old. If the patient is here, you are supposed to talk with the patient. If mother is here, you can talk to the mother, but you just need to make sure that mother has the consent from the daughter to discuss about this condition with her. So that's called guardianship consent. Any adult patient, if someone else comes to talk to you, you can't discuss their medical condition with them unless you are sure that this mother has a consent from the daughter that she can talk about the daughter. Okay, so when you start taking the history, before you say anything, so you have greeted with the mother, introduced yourself, and you say that I'm sorry to hear that your daughter had this incident, how she's feeling now. Please don't worry, I'm going to take care of her. So you say all the same thing, but once you are going to take history from the mother, you just need to ask the mother, because your daughter is 18-year-old Annie, I need to just make sure that you have the consent to discuss about your daughter condition. If mother says yes, I have the consent, then you can explain everything with the mother. You don't need to check anything from anywhere, or you don't need to ask the mother to show me the legal paperwork. That's not needed. Okay, if mother says that, you can just talk about the patient. Okay, but that's needed. But this patient, if the daughter was 17 or 16, then you don't need to do it. But once they become 18, they are an adult. So the positive point in the history was that patient was running in the marathon and she fainted during running. It was a hot sunny day. See, if you ask the history in detail, you would find out that patient had a little bit of dizziness, blurry vision, and then had a fall, and then gradually recovered. Also, you will find out this patient skipped breakfast in the morning. So on the top of that, this patient also went for a marathon running. So that made her hypoglycemic. If you ask the blood sugar level in the office test, you might get hypoglycemia. Hypoglycemia means less than 4 millimole per liter of blood sugar. So 3.6 means it's still patient is hypoglycemic. The other finding sometimes we can get in this case, that if you ask about their last menstrual period, so ask the patient, because it's the 18-year-old reproductive age, we will ask when was your child's last menstrual period. Ask that, is she sexually active? If yes, then any chance she might be pregnant. Is she using any contraceptives? The most important thing is that, is she having any trouble with her period, especially any excess bleeding during period? Why? Because it could be iron deficiency anemia, which already made this patient weak. On the top of that, she went for a marathon running without having the breakfast. This is one of the cases where you get multiple diagnoses. So there are few cases in the exam where you can get 2 or 3 diagnoses, and you are supposed to say all the diagnoses, not just a single one. So this is one of those cases. So when you got every other finding, in the physical exam, you can even get a pallor. Let's say you forgot to ask about the period history, but when you find it out in the physical exam that this patient having pallor, any pallor in an 18-year-old, we are always worried that it's most likely heavy menstrual bleeding, which is very common. After you have read the physical exam, you can go back to the patient and can ask again. So I'm really sorry that I forgot to ask. Can you please tell me about your daughter period a little bit? When was her last menstrual period? Does she bleed more than usual in her period? If you even do that, that's fine. Examiner will not fail you for it. You can always come back and find out the most important finding that you might have missed. Okay? Once you have done that, then you explain that The temporary loss of consciousness that your daughter experienced today is known as syncope. There are many reasons which can cause it, but in your child case, I am suspecting few possibilities. One is called vasovagal syncope. In this condition, in response to certain trigger, such as overexerting in hot sunny weather, can stimulate a nerve in her body, which causes pooling of blood in her legs. Because of that, there is decreased return of blood towards the heart, which means the brain is not getting enough blood supply, and that can lead to sudden faintness and collapse, just like your child case. Please don't worry, because it is a very common cause of fainting and there is nothing to worry about. She's going to be fine. Another condition that can precipitate this attack is hypoglycemia or low blood sugar. As your daughter skipped the breakfast and then had to run the marathon, this can also lead to low blood sugar, which we have also found when we checked her blood sugar today. So I'm going to give her some sugary drinks, which will increase her blood sugar and she will start to feel better. Now, if you get that pallor finding, you have to also explain. On the top of that, when I have examined your child, I have found she's looking a little bit pale. And also you told that your daughter is bleeding heavily in her period. There is a likely chance that she might have an iron deficiency anemia. So I need to do more investigations to find that out. Especially, I'm going to check her hemoglobin to look for any anemia or lack of hemoglobin in her blood, and also check her iron level. And then we can manage it accordingly. Other causes of same presentation could be due to, then you explain all other differentials. Okay, so that's the vasovagal syncope case. It depends on your finding that what you need to explain in the exam. Any question, guys? Last case for tonight, recurrent fall. Recurrent fall is usually a syncope cluster, but it's a little bit more that we need to add in here in the history. Let's see that if we can do it in our next class, because already you guys are doing a lot today. So we are going to do palpitation cluster next time, then chest pain cluster. Let's discuss this one, and then we can start with the palpitation cluster in our next. Okay. Initially, the classes are a little bit longer than usual. The reason behind is that I have to explain everything to you. Once we take few classes, the class doesn't become that much larger because you already know the format and your questions are already answered. Okay, but initially we always do it. Initially, it takes a little bit of time because you're actually understanding how this works. Okay, so that's all good. So what are the differential diagnoses of recurrent fall? A recurrent fall can be due to all the causes that we have asked in that syncope cluster. So CNS, CVS, everything is here, but we're going to add some more DD. So polypharmacy is most important. Postural hypertension would be due to medication, bleeding, diarrhea, vomiting, sepsis. Vasovagal syncope, CNS, CVS like before. Endocrine cause, especially diabetic complication, could be hypo or hyperglycemia. Could be diabetic complication like retinopathy. If patient is blind, then obviously they can have fall. If patient can't feel where they're stepping because they have a neuropathy in their foot, again, they can fall. Electrolyte abnormality, especially hyponatremia, related to vomiting, diarrhea. Anemia can cause fall, and very important to rule out this. Fall is usually a case in elderly who lives alone sometimes. So home situation is important. That what about your home situation? Any loose carpet at home? Any poor lighting at home? Okay, do you have stairs and you don't have good railing on the stairs? That can also result in fall. So lots of home situation finding we need to look for. If patient having trouble with vision and hearing, that can result in fall. Some patient can have joint problem like severe osteoarthritis, severe knee problem. Maybe patient had a stroke before that caused some balance issues that can also cause fall. So we also supposed to ask these questions in here. Okay, so these are the differential diagnoses of recurrent fall. More or less it's same like what we have done in syncope, but little bit more the differential should be added. So your history is more or less same. So you greet, introduce, ensure patient is stable if it is an acute presentation, and then you ask about the fall. So can you tell me a little bit more about your fall? How many episodes so far? Can you describe the last episode with me first? So what happened in the last episode? So same like pre-syncope, syncope, post-syncope. In here we ask, so please describe the last fall to me. What happened before you fall? So all the same questions. During fall and after fall, same questions. After you have asked the recent episode, also find out a little bit more about the previous few episodes as well. Then you go to the DD. CVS, same questions. CNS, any history of a stroke, ask about any weakness anywhere in the body, any problem with your vision or speech. For postural hypertension, same questions. That do you feel dizzy when you change your position, fever, vomiting, diarrhea, bleeding. Ask about anemia questions. Once you have asked most of the DD, go to the past medical history. In this case, past medical history will be a very important finding. So ask how is your general health, any medical condition like diabetes, stroke, high blood pressure, or any heart condition. Patient might say, yes, I am diabetic. You need to ask in detail. So how long you are diabetic? Is it well controlled? Are you regular with your specialist? Can you tell me how is your blood sugar usually in the morning to get an idea? You can also ask when was your last HbA1c and what was that? If HbA1c less than 7.5 in a diabetic patient, that means it's well controlled. Are you on any medication? If yes, what medications you are on? Now, depending on what medication he is on, you need to ask in detail. So if patient is on just oral medication, then what are the oral medications you are taking? How many times in a day? Okay, any complications related to those medications? Any problem with your vision? Any numbness, tingling sensation in your foot? So detailed diabetic history should be asked if it is positive. Find out about the medication to rule out polypharmacy, and then ask about home situation. So how is your home situation? Who do you live with at home? Have you got enough support? Any loose carpets? Any poor lighting? Any joint issues? Any problem with walking or keeping balance? Do you smoke or drink alcohol? Any known allergies? Okay, so that's your recurrent fall history. If you follow this format, that's enough for you. Most of the time in the exam, the recurrent fall is either due to polypharmacy or due to diabetic complication. When you go to the physical exam, the same thing, general appearance, vitals, BMI. But in this case, because it's a diabetic patient, we are supposed to find out diabetic retinopathy and diabetic peripheral neuropathy from the physical exam. So you should ask the eye in detail. So you would like to check the eye, especially for visual acuity, visual field, and fundoscopy. Examiner can say that there is fundoscopy findings of diabetic retinopathy. Do CVS, CNS, you would say that I would like to do complete central nervous system exam of both upper limb and lower limb, including the cranial nerve, but mostly I would like to focus on any peripheral neuropathy. And then examiner say, yes, that's positive. In face-to-face, in online, the findings will be given on the card. If patient having any joint problem, check the joint as well. And lastly, don't forget to do the office test. In BSL, you can find that patient random blood glucose is 22. What's the normal? Random is 11.1, less than 11.1 is normal. So if you get 22, it means diabetes is not well controlled. So that's your physical exam finding. So the positive point in the history, that patient had 3 falls so far, diabetic for 10 years, numbness, tingling on the foot, and also vision problem. Past history of a stroke, knee pain because of osteoarthritis. So these are the findings you have got. Physical exam, fundoscopy with retinopathy, peripheral neuropathy positive, and BSL 16. So based on that, you can say that the most likely reason of your recurrent fall is uncontrolled blood sugar causing complication. What I have found that you are having peripheral neuropathy, which means the nerves that supply our extremities, it is affected in your case in proper function. So you can't sense where you are stepping, and that might be the cause of your fall. Also, we have found some eye changes related to diabetes known as diabetic retinopathy, and that's affecting your vision. Because you can't see properly, you can have a misstep and you can easily fall. Other than that, you are also having some knee joint problem, which can lead to recurrent fall as well. This could be due to other causes as well, then give the differential diagnosis. Okay, so that's the recurrent fall explanation. Usually management doesn't come in the exam, but if it does, what we are supposed to do, that you are supposed to do all the basic blood examination. So full blood count, inflammatory marker. You should also do blood sugar level, HbA1c in this case to find out the control of diabetes. Check the lipid profile, do an ECG, okay? And after you have done that, for recurrent fall, you don't need to send the patient to hospital. What you need to do that once all the blood tests are here, you have to send this patient to a diabetic specialist who can review the medication and change the medication accordingly. Apart from that, you can also arrange a multidisciplinary team for this patient. So what we do that we involve a recurrent fall clinic, and recurrent fall clinic will involve a multidisciplinary team for the patient, which will include you as a GP who will coordinate this team. And then you can also involve an occupational therapist who can help the patient with the home situation. So they will come at home, check for any poor lighting, check for any poor stair or missing of railing on the stair. They will look for any loose carpet. So they will just check the whole home situation if it is safe for the patient, and then also manage it accordingly. You can involve a physiotherapist. They can do some exercise for the patient, which will increase their muscle strength because the patient having some knee problem and a stroke problem. You can also involve a social worker who can come and visit the patient, and the social worker can help with the cooking, can help with bathing, shower, even just taking care of the patient as a whole. Even sometimes social worker can take the patient for shopping. So everything the social worker can organize. So this is actually what the multidisciplinary team can do for the patient. If it is an elderly patient, you can also involve a geriatrician who is a geriatric doctor who can also just assess the patient accordingly for any other elderly health related complications. Okay, so that's how we manage a recurrent fall patient. Any question, guys? Now you might have understood that this is how we do the case. How many cases we have done today? At least 6 maybe. So this is why the cluster-wise approach. With just a single history and physical exam, we have done all these cases. That means you just remember that history and you don't need to do it every time you're doing a case, just remember the management and explanation, which is not very hard, I guess. So let's talk about your questions. When taking history, Dr. Annie, for each syncope case, we need ask all syncope questions, or if we find positive findings, we can focus and skip some questions. We have answered this one. Is it sufficient to give just 2 differential due to time constraint? Yes, it's always, if you have some more time, you say more DD. If you think you are lacking of time, or if you are running out of time, give more DD. Can we say that as I have checked and you have consent from your daughter, we can progress talking about it? You have to say, first you have to ask the mother that if you have the consent. You can't just say it. It depends, Dr. Pabuda. Case by case, we think about like if we need to admit the patient or not. Okay, especially if the patient comes to your emergency department, then obviously you will admit the patient for any cardiac cause to assess them further. If it's in a GP clinic, then it depends, like how is the stability of the patient. Yes, Dr. Maria, occupational therapist will review the home situation. Okay, so that's all about our today's class, everyone. So as part of the course, if you have any questions, please ask me. I'm more than happy to answer today. And Dr. Maria, in online case, we don't ask hemodynamic stability because examiner is not going to reply you, right? We explained this part initially when we discussed today. We are not supposed to ask hemodynamic stability from examiner. We just say that we are going to check it and then we move on to our next history. If patient is hemodynamically unstable, we are supposed to do some more steps. In the next class, we are going to do some of those cases where patient is hemodynamically unstable. So the next class. So when is our next class? I forgot. Let's have a look. So 10th of May. So 10th of May is cardiology class 2. We are not going to do role play. We are going to finish cardiology. Karen note is not needed, Dr. Annie. Karen notes is a very old note and a lot of, like, I think almost everything is very outdated. You don't need to read from Karen notes. Our notes is more than enough for passing the exam. Okay, so as a whole, let me give you an idea about the course so that you understand about it in more detailed way. Excuse me. Just let me share the course detail. So in the next 5 months, this is what we are going to do with you. We already know that right now you are on 2 weeks free session. That means course is actually going on. The detail of this course, you can also find it in our software or in our website. So this is the link of the website. I'm giving it in your chat box in case you have missed it. All of these are already in the Facebook group. You can always find it out from there. So the course inclusion, So we do the full theory based on cluster. That means how we did today. After that, we do the role play on this cluster. We have this 3-year sample question discussion with also notes from like at least 5 years notes of question discussion. But in your course, we are going to mainly focus on 2023 questions, the recent ones, which we are going to have few classes with Dr. Cynthia. That will be on 11th and 14th of May. You will get an idea of those random question discussion class. Those are basically just role play classes with discussion and some feedback about how you can improve. You will also receive video recording of all the role play sessions we have done in the course, which usually covers all those 5 years. Right now, we have 90 role play videos of all our previous batches, which you are supposed to get in your portal. And that covers everything. If you can go through that, that's more than enough for any preparation. I even don't ask you to do everything. Just some recent ones is more than enough. We do the physical exam, usually second month. So after 2 months of the course, we start physical examination. And that's just whole 1 month, we do just physical exam. We focus on physical exam a lot. The reason is that most of the beginner fail on the physical examinations, usually. We have a very good online as well as face-to-face format of physical exam. And if you can follow that, there is nothing that you can miss in the exam. The mini mock exam, this is actually just to find out what's your shortcomings and help you to give some better feedback so that you can improve. Mini mock exams are not 16 mock tests, 16 station exam, because we can't do that based on number of students that we get, and it's not a part of our course that we do a full mock exam. Full mock exams we do every month, and that's actually excluded from your course. Our course fee is the lowest course fee that you can get anywhere in Australia. But the course standard is one of the highest course standard among any course that you can compare. And you will not get all of this in any course with 5 months duration. If we think about business, then we would make it as a 2 months course. We can finish everything in 2 months if we want, but that will not be a good idea for you. And you will not even understand anything, because you can see that in single class today, how many questions you had and how many questions I had to answer. If I actually just focus on explaining these cases, I can't answer your questions. That's not possible, because I can't finish everything if I need to answer your questions and also explain all these cases. Someone who is doing it in 2 months, even 3 months, they're just explaining questions and not even covering 50% of your preparation. By the time your course is finished, you don't even know what you have done, and your questions are all unanswered. So we allow you to get to know us so that by 5 months' time, you actually know what's going to happen and you are well prepared to even appear the exam. So that's why. So if you're wondering about how we can't take like a full station mock exam in the full course, okay? Now, mini mock exam, usually we try to take every 4 to 6 weeks. And usually it depends how many students wants to appear the exam. Based on that, sometimes we can take 2 to 3 cases per student. Sometimes if it's a large number of students, even we can take just a 1 case with you. But that 1 case will be a detailed feedback and with proper exam kind of scenario, okay? We also take classes on communication. The recordings of every class will be in your software, usually within 24 hours. You also get a prolonged access of this recording for total 10 months of starting the course, which no one actually give you. You will get all the notes in the software until you pass. So there is no problem with your access to the notes. As part of the course, we also discuss about your CV format, selection criteria, RMO campaigns. So everything that you need to prepare so that you can actually start working in Australia. It's not about just course. Many times we help with your CV. If you send a CV to us, we help to just show you what you can do improvement. A lot of time we have done that for our students, and we still do it. Nowadays, we focus a lot on job hunting and helps you with the interview questions. So there are few things that we always try to do as part of your course. You can always claim CPD points by adding all our 65 classes in the 5 months if you're a member of RACGP or ACRAM. We also give you the course completion certificate, which you can use as a bridging course. The cost is $899. If you join initially, then we allow you 2 installation. But if you join in the middle or at the end of the course, then full fee. Duration 5 months, 3 days a week, Saturday, Sunday, and Wednesday, 8 to 10:30. If you miss any of the live class, the recording will be available, and you can always do an offline course as well. If you need to send any questions to us, if you have any queries, I would always prefer that if you send an email in this email address, because our team is more active in the email rather than in the messenger. But still, if you want, you can always send a message in the messenger. We will try our best to reach back to you. At the moment, it is the admission time. Even on Saturday, Sunday, our team works 24/7. So still, we struggle to answer your questions timely, but please make sure that if you don't get reply from us, don't take it personally. We're actually just making sure everyone get answers to us. Even sometimes there are 300 to 400 messages that comes to our messenger in a day. So if you are waiting a little bit, maybe a day, especially Saturday, Sunday, just wait a little bit, give our time a little bit of time to reach back to you. If you don't hear from us in 1 to 2 days, again, send a message. Obviously, we will answer you. This is the website where you can get all these things that I have discussed. Okay. I hope that clears everything about your course questions. There is no hide and seek in the course. We are very much frank and direct with everything that we are going to provide you. And I'm sure that you have learned about this course from others. And if others say that this is a satisfactory course for them, no one actually says that the course is satisfactory unless it is really satisfactory. And if you see all of our course reviews, that actually shows our standard. And not only that, if you look at our every month exam result, that's more than enough to show how much standard we try to maintain to run this course. Okay, I hope that you get what you want from the course. I hope that the dream to be a doctor in Australia, it becomes earlier than later. And most of the time, all of our candidates who pass the clinical exam, they are first-time attempt candidates. Okay, so hopefully you will be the one who we can share your results with others. So the course will end in 5 months, so most likely in October. Apart from handbook, Dr. Sarah, which book or note should our reference book for detail? There should not be any other book that you need apart from the course notes. So handbook and course notes, that's more than enough. People read a lot of other things, like some read from Marwan. I think some reads from some other notes. I can't remember their name. If you want, you can always read that. But I would always say that make just a single note that you can revise when you are appearing the exam. Don't go through a lot of things and just waste your time. It's more important to do role play than going through a lot of notes. About the PESCI, this is clinical course at the moment. PESCI, we are not discussing here. So either you can reach me in the messenger, we can discuss about it. And the PESCI course is going to start at the end of this month. There will be a trial class for PISCI. I think that was on 26th of May. Just make sure you join that class for any questions. Yes, you will receive all the theory notes, everything that we are giving in here will be in your portal once you join the course. Okay, hopefully that answers all of your questions. Again, you can answer any questions that you have in your head in the next few sessions. We still have a lot of free sessions with you. Hopefully you will get to know us better by that time. Thank you, everyone. Have a good night. Take care. Bye.